Good morning, everyone. Today's lecture topic is on oral hypoglycemic agents. So, in this, we are going to study what are the drugs which are going to help to reduce your blood sugar level. So, and those drugs we are giving orally. And I am Dr. M. I. Shuja from Department of Pharmacology, Faculty of Medicine and Allied Science, Rajarata University of Sri Lanka. Okay. First, before going to see what are the drugs and what's their effect, you should better know the basic regulation of blood glucose level. There are two or three major organs and two hormones are involved. Those three major organs are, one is pancreas, other one is liver, other one is skeletal muscle or tissues. And two hormones are insulin and glucagon. You all aware diabetes where either insulin deficiency or absence of insulin, or you have enough insulin but it cannot exert their effect at certain receptor level. There is some kind of resistance at receptor level. So these two are the major pathological changes. So here, if you look at when there is a high blood sugar, those will promote insulin release from the pancreas, beta cells. Then those insulin stimulate glucose uptake from the blood. So it reduces the blood glucose level in the periphery. Again, it will stimulate the glycogen formation. So wherever you have excess glucose, that is converted into glycogen and stored at cells, especially the liver. This is happens in the and your blood sugar level is going up. So by your own feedback or negative feedback mechanism, we tell it hyperglycemia, or in other words, diabetes mellitus. Not all hyperglycemia are diabetes mellitus. You have certain criteria for that. So, if it is not happening, we are using either you can give insulin from outside or you can use drugs which are increase the secretion of a pancreas. So pancreas is secreting insulin. So one thing you do is you can give drugs which are going to stimulate of insulin. Or else you can we are going to increase the sensitivity for insulin. So these two are the major of drugs. Of course, there are other few categories. They worked at the kidney level, did not allow reabsorption of the glucose. Some drugs works at the gastrointestinal tract. They didn't allow the reabsorption from the, not reabsorption, they didn't allow absorption from the gut lumen. So there are other categories of. We'll be looking one by one in detail. What is normal blood glucose? And if the problem to correct it. So allocate 1 or 2 minutes to go through this slide. Then go to the next slide. So diabetes mellitus, as I mentioned, it is either deficient or absence of insulin or insulin resistant in the body. So you know what are micro and macro. It is where the resistance, insulin resistance comes 80 to usually occurs over age of 35. Obesity is an important factor. I am not obese, so hopefully I will not have diabetes mellitus. So there are two pathophysiologies: abnormal insulin secretion, that's number one, or resistance to insulin to act at the target tissues. So these are two pathophysiologies we have explained. Treatment modalities of type 2 diabetes, dietary management. Then we are going to fix the calorie intake and your weight. Then increase physical activity. And the last one is anti-diabetic drugs. Either it can be insulin or oral hypoglycemic agent. Today we are going to mainly discuss about oral hypoglycemic agent. So the oral hypoglycemic agent, you can give that alone or you can combine that with insulin. And never forget lifestyle, eating habit, physical activity, and sleeping habit. So it's just a figure showing. Here you have no diabetes. The ability to secrete insulin is gradually decreasing. So diabetes is starting. You can control that with diet initially when there is impaired glucose tolerance. Once you diagnose diabetes, you have to put diet and other drugs. So if you are taking medication and proper drug, then relatively you can shift the curve in this range from here to here. Then you can maintain. So now we saw what will happen in diabetes. So reduce insulin secretion or insulin sensitivity reduces, blood glucose level is increased. So what these oral hypoglycemic agents are going to do? What are the pharmacological basis of the drug action? The insulin production. When you have enough insulin, then it reduces the hepatic glucose production. So one of the major organ where gluconeogenesis is happens is liver. Then it can increase insulin sensitivity. Then it can reduce gastrointestinal glucose absorption. So your blood glucose level is going to be reduced. Then it will reduce renal tubular glucose reabsorption. These are the major pathways how these oral hypoglycemic agents are going to act. Remember that each pathway is done by separate class of drugs. So this is just a overall idea where these agents, oral hypoglycemic agents or OHA, are going to act. They act on liver. What they do in the liver? They reduce glucose production. What are the drugs? Biguanide, hydroxylodinone. Then at intestinal level, it reduces glucose. The drug, alpha glucosidase inhibitor. At pancreas, what it does? It increase insulin, like insulin, meglitinides. And at adipose tissues, is increase peripheral glucose uptake, biguanide, thiazolidine. So via action at these sites, it will increase. Again, allocate 2-3 minutes to go through this slide and understand it. So what are the types or classes of drugs? Biguanides, sulfonylureas, glitazones, TPP4, that is dipeptidyl peptidase 4 inhibitors, SGLT2 inhibitors, sodium glucose 4 transport inhibitors, alpha glucosidase inhibitors, meglitinides. So we will look one by one. There are mode of action, insulin secretory. Insulin secretion. Sulfonyl like incretin like. So what are causing insulin sensitization? Biguanide, that is metformin, thiazolidinediones, and other agents where they block. Is coming under biguanides family. First line drug in diabetes mellitus. If you see in the hospital, the patient is diagnosed with diabetes, especially type 2, the doctors initially start him with metformin. It promotes weight loss. That's a good advantage. Because some people, they don't have diabetes, but they are obese. What they do is they have metformin every day to reduce the weight. So that is one of the benefit of having metformin. So as we mentioned earlier, the ideal purpose of any oral hypoglycemic agent is to reduce the blood glucose level. So either it can reduce the blood glucose production or it can take the glucose within the blood to the cells or tissue. So metformin, the pharmacological actions are it reduces hepatic glucose production, it increases insulin sensitivity at the receptor level, increase glucose uptake in skeletal muscle, fat tissues, reduces the LDL, that is a bad lipoprotein, increases HDL, that is a good lipoprotein. So what is the mechanism of action? So these metformin, they stimulate AMP activated protein kinases. So these AMP activated protein kinases, they influence metabolic regulation. So they regulate cellular energy metabolism. It eventually causes increase in hepatic insulin sensitivity or reduction in the hepatic glucose production. This is just a diagram. The metformin comes and binds in the hepatocyte. The site of action of metformin is liver cell. It goes, it initiate increase AMP. So it forms AMPK. AMPK is AMP activated protein kinase. So this AMPK via other pathways reduce hepatic glucose production. It's a complex pathway. You don't need to remember everything. But no, metformin via increasing AMP level, increase AMPK, that AMPK via other transcription factor formation and gene expression pathways reduce glucose, that means glucose production in the hepatocytes. So it's a monotherapy, best taken with or after meal. So nowadays they prefer have metformin with the meal. You have slow release production and immediate release production. You can combine the metformin with any oral hypoglycemic agent, other drug, or even with the insulin. There's a low risk of hypoglycemia. That is one of the good, that's beneficial thing. So the hypoglycemia risk is very low. It is also used in polycystic ovarian diseases and gestational diabetes mellitus. The few pharmacokinetic things, this you have to remember. The oral bioavailability is 50 to 60%. It has a very low plasma binding. So few books say there is no plasma protein binding, but the proper term I prefer is very low plasma protein binding. It is not metabolized in the liver. It is not metabolized in the liver. It is excreted via the kidney. So when you have kidney problems, the excretion can be altered. The duration of action is 6 to 8 hours. But the metformin is ineffective in the absence of insulin because the metformin is going to mainly one of the sensitizer at the receptor level. So if you are going to sensitize receptor, you definitely need a ligand. So when there is no insulin in your body, metformin is ineffective. It does not affect insulin secretion, not induce hypoglycemia, not predisposed to weight gain, because with few oral hypoglycemic agents, they tend to put, in addition to its effect on glucose, it may also suppress appetite stability. The drug of choice for type 2 diabetes mellitus, but in type 1 can be used in conjunction with the insulin. So any drug is having side effects. So mainly metformin is having GIT side effects. Anorexia, nausea, abdominal discomfort, diarrhea, metallic taste in the mouth, and rarely lactic acidosis. It's best drug to start as a test line. In renal impairment patient, usually you don't start metformin saving EGR of less than 55. But we have already started on a normal person, and if his GFR is falling into some issues, when GFR falls to the person. So no difference, okay? In a person, we don't know. We just diagnose him with a diabetic mellitus, and you are going to start metformin. So you know metformin is not metabolized in the liver. So all the equation is done by the kidney. So your kidney function should be handled. So you check GFR, it's less than 45. Then you are GFR randomly annual checkup. It's become 25 below 30. Now you are going to stop that and convert into another oral hypoglycemic agent. So know the difference. This point is very important. It will be asked the MCQs to assess you. So usually tend to increase lactic acid level in the people who are predisposed to that. So therefore metformin is suggested in the patient who is having lactic acid. You can combine metformin with any oral hypoglycemic agent and insulin. Let's go through before surgery what you are doing with the metformin. And the second group of drug is sulfonylureas. This is one of the another major class of drug. It also stimulates pancreatic insulin secretion. Metformin stimulates sensitivity for insulin and the receptor level. Know the difference. So it's glucose independent action. You can give that the monotherapy or you can combine with other drugs or insulin. It's taken before meal. There are varying duration of action. Depends on the generation of sulfonylurea. There are first generation, there are second generation. So the risk of hypoglycemia is greater with the longer duration of action. So the mechanism of action, the book says, stimulate insulin release from functioning B cells or beta cells by blocking ATP sensitive potassium, which causes depolarization and opening of voltage dependent calcium channel, which causes an increase in intracellular calcium in the beta cells, which stimulate insulin release. So what we can do is just forget about it. Okay. Now I'm going to review step by step, easy way how sulfonylurea is acting. So first, the sulfonylurea is bind to sulfonylurea receptor. Then it blocks ATP sensitive potassium channel on the beta cell plasma membrane. So when it blocks the efflux or going out of the potassium is restricted. When the going out of the potassium is restricted, there is no repolarization. So partial depolarization occurs. This depolarization activated or opens voltage gated calcium channel. So the calcium comes in. So this calcium increase the secretion of preform insulin in response to glucose. Okay. So like the calcium release acetylcholine at neuromuscular junction, here release already preformed insulin. Hope now you understand. So this is again a complex graph. Don't look at that. Or if you like, you can look at it. So the easy graph is the sulfonylurea. It blocks potassium channel, ATP dependent potassium channel. So it closes, depolarization occurs, the calcium channel depolarized, calcium comes in, the calcium increase the free-form insulin secretion. The insulin goes happily and acts at the receptor. Again, I make it easy due to increased hypoglycemia. Here, drugs. There's a blockade of ATP-dependent potassium channel. That in turn opens voltage-dependent calcium channel. So increase intracellular calcium in the beta cell, increase insulin release. So there are two generations, first generation, second generation. There are short acting, long acting. That first generation sulbutamide, clopidogrel. Second generation, evenlamide, glimepiride, glycoside. Now they don't usually go for such glycoside, glipizide are commonly prescribed by general practitioner. So why you need a second generation? Because it is more potent than first generation. Have a longer duration of action. So if you are having a longer duration of action, lesser the frequency we use. So lesser the frequency we use, we don't forget to use. So the compliance is good. And it has few adverse effects and few drug interactions. So this chart, I have made it to make your life more easier. Actually, what you have to do is you have to go through the book, you have to prepare the chart like that. My students are very busy, so I make their life bit. So few of the extra pancreatic actions, I mentioned that it stimulates the appetite, so it tends to put you on weight. Okay. They have mentioned for a successful therapy, at least you should have the 30% of the normal beta cell function. Sulfonylureas, it can be used as an alternative sustained agent where metformin is contraindicated or not tolerated. The contraindications are, so each has to discuss indication, side effect, mechanism of action, contraindications. All I have prepared a supplemental note, a PDF version. Usually I give some of the physical chapters for my students. So I will be giving you that. So don't worry, you can go through that. But also check that with the BNF, the latest edition of the BNF, and study. So usually we start metformin as a first line. When there's a contraindication or there's too much of side effects and the patient cannot tolerate, we are giving sulfonylurea. That is what is mentioned in the second form. Then it will absorb orally. It's bind strongly to the plasma albumin, 90%. The metformin, it is very low plasma albumin binding. So when you study, you can make a chart, compare metformin, sulfonylureas, glitazone, and other gut meglitinides. Like that, you can prepare your own summary. But don't worry, I am giving that again. So most sulfonylureas are excreted in the urine. So the action is increased or prolonged in the presence of renal disease. As they are excreted in the urine, if you have problem in the kidney, reduce. So the amount is retained in your body is increased. So the action is increased. So you may get the peak concentration reached after 2 to 4 hours in metabolic nothing to do with liver. Yeah, it can cross the placenta and it also enters the breast milk. If it is cross the placenta, it stimulates fetal beta cell to release insulin. So it can cause hypoglycemia at birth. Okay. So usually use is contraindicated in pregnancy and breastfeeding because of this. This can be asked in your SEQ. Why? In pregnancy, sulfonylureas not recommended or contraindicated. And you have to be explained. So these are just we have I have explained. Just go through this. Okay. There are few facts you need to remember. What is the active metabolites? What are the inactive metabolites? How these metabolites are excreted? What are the ways? Either in the renal. To remember. Patient with impaired renal function, glycoside, glipizide, and tolbutamide preferred because excreted by the cyst. High risk of hypoglycemia with glibenclamide. So one of the side effects is weight gain, and it can cause hypoglycemia. And there may be hypersensitive reaction, like right. Risk of hypoglycemia is increased with sulfonylureas, excessive alcohol intake, age, so if they are, why there is a risk of hypoglycemia in old age? Then you have to explain. Sulfonylureas are excreted via the kidney. In the old age, the kidney function is gradually decreases. So GFR is reduced. So excretory function can be altered. So that leads to retention of the immune system. So there is longer action of that sulfonylurea in your system. When sulfonylurea is acting for a longer time, there's a risk of increased hypoglycemia or else increased risk of hypoglycemia. That's how we are going to explain. Okay. You have to narrate your answer in a like a storytelling, one by one. What is happening? One by one. Okay. That's the best way of narrating an answer, like a story. So the examiner is happy to read. So there are few drug interactions. Remember that. And remember type of drug. This class is thiazolidinediones. So this what is doing is a stop the peroxisome proliferate activated receptor gamma. That is PPAR gamma. Nuclear transcription. Regulate this nuclear transcription receptor and regulate energy metabolism. So via that it maintains a proper insulin regulation. It's again insulin sensitizer, increase transcription of insulin response genes, activate genes regulating fatty acid metabolism, reduce hepatic glucose production, enhances peripheral glucose uptake, reduce triglycerides, increase HDL, the good lipoprotein, and increase adiponectin levels, a cytokine which can increase insulin sensitivity. So these are pathway, thiazolidinediones comes and regulate PPAR gamma. It in turn regulate the glucose and fatty acids. Just go through this. It can be either used as monotherapy or combined with any other drugs, any other anti-diabetic drugs or insulin. It also not causes hypoglycemia. The side effects are weight gain, fluid retention, peripheral edema, increased risk of fracture, and usually no risk of hypoglycemia. Know this. These drugs are having side effect with the edema and water retention. Again, the latest and the wonderful drug is dipeptidase 4 inhibitor. So it is a wonderful physiology. They just go through. Okay. So you see there are incretin and GLP-1. These incretin and GLP-1 stimulate insulin release and meantime inhibit glucagon release. So they lower blood glucose. That is the normal function. But in body, for effect, you need incretin GLP-1. But there's an your body DPP4 enzyme that inactivates the GLP-1. So the lowering of the blood glucose can be impaired. What we are doing is we are blocking enzyme DPP enzyme in. So, the inhibition of these enzyme on GLP-1 is what happens? GLP is so it for your blood glucose level. This is the physiology behind it. Hope you understood. It prevents degradation of insulin hormone, GLP-1 and GLP-1 appears from small intestine following week. DPP4 inhibitors, they prevent degradation of these incretins. We call these incretins by DPP4. Release dependent manner. So glucose level is reduced. This both mechanism action is very wonderful, very easy to understand. Know this. So how do you remember it? Just go through each mechanism of action slide and take a piece of paper, write your, then compare. Okay. This mechanism of action of drugs is important because we'll be looking at the essay questions. So the few names type inhibitors, sitagliptin, all the drugs finished with gliptin is mainly DPP. So they given orally as a neutrality, that means no weight gain, the minimal risk of hypoglycemia. It can be safely used in patient with renal impairment. They are most excreted renally. Those adjustments are needed in renal impairment. Although linagliptin is mostly excreted through GI tract, you don't need to adjust renal dose or is an alternative to metformin in renal impairment because linagliptin is excreted via the gastrointestinal tract. So if you have renal impairment, we, we have seen earlier, initially, if you want to start a metformin, if the GFR is less than 45, you are not starting. So in that situation, you can use linagliptin. So just go through these, remember these facts, okay? The duration of action, what is the mode of excretion, and how do you need a reduction in the renal impairment or liver diseases, especially the dose. The few side effects are nausea, anorexia, weight loss, nasopharyngitis, and allergy reaction. And they say there's an increased incidence of pancreatitis reported. Other drug is sodium glucose for transport inhibitor. So there's usually a, during diuretics we have seen the physiology. So there's a glucose reabsorption from the proximal convoluted tubules. So it blocks that. So increase glycosuria, that means glucose in the urine. So reduce glucose load in the blood. The few drugs are empagliflozin, dapagliflozin, canagliflozin. Empagliflozin is nowadays famous drug in the market. Monotherapy. I'm not promoting any drugs, but I'm just telling what is happening around you. Okay. What are the drugs commonly prescribed by general practitioners? It can be used as a monotherapy or a combination. Can give orally or once daily dosing. No risk of hypoglycemia, moderate weight loss, problem with the technology.